Welcome to the CodeCast Podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the CodeCast Podcast. Today, my name is Terry Fletcher, and it is the last Tuesday of the month, so you know what that means. It is Top 10 Tuesday, and I'm going to focus a little on telehealth since we just had the PHE renewed, the public health emergency, and there is a lot of auditing going on, and I just want you to have a checklist of things you should be looking at when you are making sure you're compliant with telehealth and that you're looking at all angles when you're trying to make sure that you're not in any kind of compliance risk with telehealth. Currently, the Office of Inspector General, they published a report in September, and it's called Medicare Telehealth Services During the First Year of the Pandemic Program Integrity Risks. And there's measures in there that explain what they found, and some of the things are not good. So if your practice makes a mistake, a lot of the healthcare attorneys out there are saying it's not the end of the world as long as you take the right steps in response. And a lot of times those steps in response are not just self-reporting, but if you find errors, but also making sure that you have a corrective action plan. It means that you've identified the problem, your plan is to fix the problem, everyone's been educated on the problem and how to fix it, and you have that in writing. So one of the things I know that has been really tough, and you heard me probably say this before, is everyone had to pivot pretty quickly when we hit the pandemic in 2020, which was March 1st. So it actually was January, but the implementation of the telehealth expansion under the CARES Act, the waivers 1135, basically it was everybody saying, okay, how does this work? And I was teaching telehealth for a couple of years before the pandemic hit, but it looked a lot different than it does now. So we had originating sites that was not the patient's home. We had distant sites that were a little bit different, and if they were in a facility, that site could charge for different things. So there was just a lot of billing rules that had changed almost 95%. So here's some steps that you can take when you review your practice's telehealth claims, and you really need to review them. I can't stress enough how important it is to review these claims because the OIG, the HHS, CMS, they are now saying, okay, we're reaching the endemic, you should have known better, and we gave you the rules after rules after rules in the fee-for-service FAQ sheets, and there's no reason why you shouldn't have done it correctly. So let me just make sure that you have that checklist, and you may need to play this back at a later time just so that you can actually write it down. So first of all, read the data brief, okay? The OIG data brief, it's actually a pretty useful compliance roadmap for providers, and it should inspire both providers and telemedicine companies, because I know they're kind of in your face a little bit, to take a closer look at internal coding, billing, auditing, and monitoring practices. You have to have checks and balances. Otherwise, what's happening right now, especially in behavioral health and certain primary care practices, is that they are reporting telehealth incorrectly for the convenience of the patient, not because they're trying to slow or stop the spread of COVID. Remember, we just had the public health emergency renewed, which goes through January 15th, 2023. And yes, certain flexibilities are still there, but we will have an end date. And I actually could bet my life on this one that this is the last one. So unless there is such a surge where we see a 50% increase in what we're seeing now, I just don't see it being renewed. Mainly because we also have the CAA, which is the Consolidation Appropriations Act, which was an act of Congress in 2022 updated, that allows for another 151 days of some of the flexibilities to still be in place once the PHE ends, which will help with the transition. And also there's some, I think they're part 3, they call them, or category 3 of the telehealth list, that basically it says that those will end at the end of the year that the pandemic ends. So they still are going to be at the end of next year. So it's, everybody's like, oh my gosh, when it ends, we don't have a chance. You should always be planning. So the first thing, number one, would be read the data brief. It's very helpful. The next thing, increase your red flag knowledge. So The HHS, the Department of Health and Human Services, they actually have a list of common telehealth billing mistakes when you review claims. So first of all, the wrong codes. The wrong code can delay payments or cause improper payments. So can the wrong modifier. I see that a lot of practices forgot to put the 95 modifier on, and now payers are saying, well, you didn't put that on, so that means you told us you billed an E&M service, saying that the patient was in clinic, because we still use the place of service where they would have been had we not had a pandemic, and you're falsely reporting that code. And so that's a problem. You have to put the 95 on it to reflect during the public health emergency that is a telehealth visit. So that's being flagged. If you didn't put that on there, some of the payers, the Medicare administrative contractors, are asking for that money back. Also, for those of you that billed for office visits for telephone codes and audio only, you could be in trouble because that's an improper coding. So you want to make sure you're not coding for that. And then also for anybody that coded phone call codes, the 99441 to 443 and the 98966 to 98968 for staff who can report it, not RNs, not LVNs, LPNs, but like clinical social workers, physical therapists, etc. And you weren't mindful of first the established patient guideline and also the 7-day, I call it a global guideline, meaning that there cannot be a related visit within 7 days. So let's say that you have a patient that either came into the office or had a E&M service under telehealth virtual. And so you build it, let's say a 99214. Patient calls back 3 or 4 days later to get a clarification on their medication. That is free. It's always been free. It's a clarification. Even if they called back 2 weeks later, you can't have it. But the big problem with that there is you're now not only in violation of medical necessity rules and of compliance rules, but you're in violation of the rules for phone call codes. First of all, it has to be something that is something that you would bill in place of an E&M. Do you have a patient come in if they need a clarification? And secondly, there's that 7-day rule. So I'm seeing that happen all the time, and that's a problem. Also, the wrong documentation. You have to document. So in addition to meeting the documentation requirements for the services, you also have to document whether the patient gave you verbal or written consent to conduct a virtual appointment. It's a little gray in the FAQ fee-for-service FFS sheet, but it's in there. And according to the HHS, it says also the provider must clearly document whether the connection was audio and video only or audio only. So they want to know what you're doing. That you have to make sure that it's in there. Another common mistake, and this is something that's really important, is that if the healthcare provider is billing on time, and this is also an E&M mistake, they're including time that the patient spent with the clinical staff. So they're timing the visit as soon as the visit is, if it's telehealth, is turned on, if you will. And so now the staff is getting a consent, the staff is getting vitals, the staff is, doing stuff to prepare for the chart, and they're trying to use that total time of that visit as to level their service, and they can't do that. Remember, the E&M services, you still have to follow their guidelines, and the total time has to be only what the provider spent, not the ancillary staff. So only what you spent with the patient, meaning the provider, can be used for time. Can the other staff do all those services? Absolutely. You just can't count it towards the time of the visit. And it's made a big difference, the difference between level 3s and 4s and level 4s and 5s and my auditing services. So I'm just like, oh my goodness, you guys have to stop doing that. Also, you don't really need to drop everything and start a full-scale review of every claim if you find one error, but don't ignore an error. So if you find that there is an error, find out what caused that mistake, figure out the scope of that error. So is it something that was repeated and ongoing? And if there should be an overpayment, then you need to send that back. Conduct a thorough analysis of what caused the error. So if, the organization should find the root cause of, what triggered this error or what somebody knew or didn't know. I know sometimes, I'm sure some of you have heard this, well, we were told to do it that way. By whom? I get a lot of people saying, well, we were told. Okay, who told you that? And they look at each other going, I don't know. Well, you need to find out who actually told you that. So you also need to make sure that you're not always, and I'm air quoting, doing things the way we always have. So this was specifically because of the pandemic that we've been able to open up telehealth. It is going to stay open to a certain extent once the PHE ends, once the CAA expires, but they're closing off phone calls once that expires, except on for mental and behavioral health on a short leash. So for certain diagnoses, so be careful with that. And then, I say this, but it's not to generate business for me. I mean, call me if you need me and we can set something up. But if you discover a serious issue, such as dozens of incorrect claims or signs that could point to, and I hate to use the word fraud, but a fraudulent problem, or let's just say a false claim act issue, then this is where you need to work either with somebody in counsel or you need to get a more expansive audit. And I would strongly urge you to look outside of your practice. And that's something we do. So feel free to, send us an email if you feel like you don't have the staff to do an internal audit and you want us to take a look. So, right now I think I have, oh my goodness, for telehealth audits, I'm looking right now, I've got 190 that I'm looking at, and I'm looking at another 400 for a payer. So I do both payer and physician audits. And it actually gives me a good insight because I can see, something, if a Medicare payer contracts with me or commercial plan, United Healthcare just loves to say, hey, I need some help. Or, the physicians themselves. So different specialties, different practice, just to see how they got their information, how it was utilized, and then what's happening especially within multiple physician practices, because you always have an outlier. There's always somebody that says, well, I want to do it this way. Or you get another provider that came from an outside clinic and they're like, well, this is what we did where I used to work. Well, that doesn't mean that's what you do here. And so it's just really important to take a look. Don't push this to the side because they are definitely, when I say they, HHS and Medicare, they're coming for you. So are the private payers. And document everything you do, okay? If it isn't documented, it's not done. Everybody says that. That also applies to compliance efforts, as well as physicians' work and, medical record documentation. A written record of the steps the practice took will help build the practice compliance plan and prevent mistakes in the future. And if the worst happens and you are investigated, then you can actually show the government or the payer that you tried to do the right thing and your intent was to identify corrective action and not let it happen again. And if it's necessary, to refund if there's something that you do find. And this is such an important concept for payers to know that you're heads up about it, that you don't basically just find something when somebody else catches you. So it's something that internally or hire somebody externally to take a look at these things to make sure that you're on the up and up, that you are compliant, and that you're not going to have a problem as we now get into the fourth quarter of 2022. Biggest thing to keep in mind, first of all, are you still doing the telehealth to slow or stop the spread of COVID? I can't stop saying slop. It's stop. If that is the case, then you're fine. Like I have oncology practices. Those patients have compromised immune systems. I can see that. Certain cardiovascular patients, COPD, AFib, patients that really have a hard time getting around, or they've got respiratory issues, my pulmonary offices. But if you have healthy patients in an otherwise protected practice where everybody's vaccinated, you're following the protocols for keeping things as clean as possible and sterilized, and the patient's just there because of convenience, because they don't want to travel or they don't want to park or they don't want to, get in their car, you could have a problem that may not be acting in good faith. It could be acting in bad faith. So check with the payer. I know, for example, with my insurance, I have an EPO, and I think it's under Blue Cross Blue Shield Anthem. I do have telehealth coverage, but here's the kicker. I can't go to my normal doctor. If I want a telehealth visit where they waive the copay and the deductible, I actually have to use their panel physicians. And I know a lot of insurance companies have incorporated that practice back after they ended a lot of the waivers and a lot of the pandemic changes. Some people have, insurance that will allow them to see their own physician for a telehealth, but there are rules on there. And there's also out-of-pockets, and there's also maybe some limitations on how often they can do that. I actually have one payer in the Cigna payer plan that actually has specific diagnoses that you can use for telehealth. If you don't fall in that diagnosis category, then they don't do it. Because remember, the only thing that the payers have to do is offer it. They don't have to cover everything. So Medicare is still about the same. The only change with Medicare that they came up with in April, they finally told us, is that the government does not run the states when it comes to cross-state care. So if you have a patient that's in Florida and your doctor is in New York, that doctor cannot treat or see the patient in Florida via telehealth unless they are licensed in the state where the patient is. And so that's a really big deal. Make sure you're checking on your state information as well and the dates that those waivers expired. Okay, so my coding question today, even though that was a little bit coding, I did want to also offer a coding question because I thought this was interesting. So many of you know that cardiology is my number one specialty. Well, it's not my only specialty, but it is my number one specialty. So a question came in about cardiac ablations, and there was an ablation in the pulmonary vein for atrial fibrillation, 93656. And then the question was, once the procedure was performed, the physician crossed the right atrium and the patient continued to have symptoms, which was documented as A-flutter. Since the provider listed an additional diagnosis in a separate chamber, can we also code the 93657 for this procedure? So here's the thing on that. Additional symptoms doesn't mean additional diagnosis isolate, and that's what they're looking for. Also remember, A-flutter is not AFib. It is a symptom that could lead to atrial fibrillation, but it's not atrial fibrillation. So it's basically just kind of a weakened area. And the 93657 add-on code for an additional ablation area is not to complete the original ablation, is for AFib. So you may have some payers saying that's not atrial fibrillation, that's just a sign that there could be some areas there that the doctor needs to clean up. So you kind of take your chances if you try to code for that based on an A-flutter diagnosis. It would have to be AFib for that to be reimbursed without an issue there. My personal tidbit this week, oh my goodness, it's been such a tough transition to come back from vacation in Hawaii and then get back into work, but I'm doing it. I'm doing the best I can. It's just hard sometimes because all of a sudden you're like, oh my gosh, the catch up is crazy. But I just wanted to kind of shout out the Hawaiian people, the Four Seasons. We had such a good time, and I'm still tan. I actually feel like one big freckle, but we had a great time, and there's nothing better than great customer service, just really making myself, my husband, my daughter, and her husband just feel really welcome, and it was a great family time. So back to work, though. I also celebrated my birthday there, so it's always fun to know that you live another year. And we also had a Steelers win on my day back, so I was pretty excited about that. Beating Tom Brady, no matter what the situation is, just warms my heart. So that's where we're at with that. So let's hope we can have another win in Miami this weekend. All right, everyone, make it a great day. That's it for me this week, and actually this month. The next time you will hear from me will be on November 1st. And everyone, just make it a great day, a great week, and thank you for listening to the CodeCast Podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.